Dr. Ken Landau, thanks for watching. Let's talk about Ropinirole or Requip. Two forms available, immediate release and extended release. Immediate release was approved by the Food and Drug Administration 1997. The drug went generic in 2008, which means the price went down. It was affordable. Then the extended release was released in 2008. Its price got expensive again. And then the company, because the immediate release Requip couldn't compete with the generics, drug company took it off the market in 2019. So now it's just generic for the immediate release. The drug is the 108th most frequently prescribed medicine in the United States. More than 7 million prescriptions will be written this year for the drug. It's approved for Parkinson's disease, and later on, in 2005, it received approval for treatment of Restless Leg Syndrome, or RLS. For Parkinson's disease, it treats the extrapyramidal symptoms. The extrapyramidal symptoms are rigidity, the slowness of movement, we call it bradykinesia, the stiffness, the tremors, and the dystonias. Those are the muscle spasms, muscle contractions associated with Parkinson's disease. And it's used off-label. Sometimes people are taking the SSRIs, those drugs like Prozac and Zoloft and the Lexapro. They can cause some problems. They can cause Parkinson-like syndrome. So then you might want to correct that problem with the Ropinirole, or better yet, switch to a non-SSRI antidepressant. And sometimes people taking the SSRIs or the atypical antipsychotics, drugs like Abilify or Risperdal or Zyprexa, they can develop sexual dysfunction, erectile dysfunction. And it seems that, again, the Ropinirole might be helpful for those conditions, or you could switch to a different medicine. Then they're evaluating to see whether it's of any value in ALS. That's, say, myotrophic lateral sclerosis or Lou Gehrig's disease. But let's talk about Parkinson's for a moment. Parkinson's is the second most common neurodegenerative disease, ranks right after Alzheimer's disease. It affects about 1% of the population over age 60, and it's caused by a selective loss of the dopamine manufacturing cells in the striatum nigrum, part of the brain. So it's a progressive neurodegenerative disease, and it has motor symptoms. Those are the symptoms that we talked about a moment ago, the slowness of movement, the bradykinesia, or the rigidity, or the resting tremor, sometimes a postural instability. And then it's also associated with non-motor symptoms like sleep disturbances, or mood problems, or behavioral disorders, cognitive dysfunction, mental dysfunction, and sometimes autonomic nervous instability, change in the blood pressure, change in the heart rate. Well, we judge medicines, whether they're working or not working, by the on time and the off time. The on time is when the symptoms go away and you seem to be doing fine. The off time is when the medicine isn't doing so well, typically due to the medicine wearing off. The symptoms are now not in control. Those dyskinesias and the Parkinsonianism type movements start coming back. The risk of those symptoms, the risk of having more off time, is if you've had the disease greater than 1 year. If you're taking the treatment, especially the levodopa, for a longer period of time, a higher dose of levodopa, or you're a younger individual, or the disease is of greater severity. How do we treat Parkinson's? There are a variety of different kinds of medicines available. Typically, it's levodopa combined with carbidopa. That's the most popular therapy. But then we could use some of the dopamine agonists. They don't really increase the amount of dopamine, but they mimic the effects of dopamine. That's the Requip, or the Ropinirole, or the Mirapex, or the pramipexole. Then we have the catechol-methyltransferase inhibitors, and we have the anticholinergic like cogentin, and we have the MAOB inhibitors like selegiline, we have amantadine, and sometimes people undergo some surgery, some deep brain stimulation, and sometimes that works. That's being pushed, but... So anyway, for restless leg syndrome, it seems that when the drug first became available, it was thought to be a wonderful treatment. But it came available on the basis of short studies with relatively few individuals. And the more we learned about the medicine, the more we learned about some of the side effects of taking the medicine, now it sort of is reserved for people who have moderate to severe restless leg syndrome who aren't controlled by other kind of medicines. Other kind of medicines, oftentimes the gabapentin or the Lyrica or a variety of other medicines. But probably the ropinirole is not a first choice. If you're going to take the medicine and you have Parkinson's disease and you're taking the immediate release form, you have to take it 3 times a day. So you slowly increase the dose. So you start off for the first week at taking 0.25 milligrams 3 times a day, then the second week 0.5 milligrams 3 times a day, third week 0.75 milligrams 3 times a day, fourth week 1 milligram 3 times a day, and then you slowly increase it over the subsequent many weeks up to a maximum dose of 24 milligrams a day. So that's 8 milligrams taken 3 times a day. And once you get to a level of 8 milligrams or higher, then typically you can start to gradually reduce the levodopa amount if you happen to be taking that drug too. And if you decide you want to come off the ropinirole, you don't stop suddenly. What you do is you taper over the course of about a week. So you go from taking it routinely at 3 times a day, and for 4 days you take it at twice a day, and then for another 3 days you take it once a day, then you come off. If you want the extended release, because it bugs you having to take 3 pills a day when you only have to take 1 pill a day, you could take the extended release. Take it once daily, with or without food, doesn't seem to make any difference, but you swallow the pill whole because it's extended release. You don't chew it and crush it or divide it because you change the way it works. So when you start with the extended release, you start with 2 milligrams once a day for the first 1 to 2 weeks, then you gradually, slowly increase it again to a maximum of 24 milligrams a day. And as with the immediate release, once you get to more than 8 milligrams a day, then you start to reduce the levodopa if you're taking it. And if you decide you want to stop the ropinirole again with the extended release, you stop it over the course of a week. Now, the dose, even though we said that the maximum dose is about 24 milligrams a day, but only about 18 milligrams a day if you happen to have renal disorder, well, even though those are the max doses, practically the maintenance dose, if you have early Parkinson's disease and you're taking it as the sole therapy and you're not taking the levodopa, chances are you want to keep the dose to 12 milligrams or less a day. And if you have advanced Parkinson's disease, you probably want to keep the dose with the levodopa to somewhere around 8 milligrams or less a day. Now, if you have the restless leg syndrome, you take a different dose. And not only do you take a different dose, you only take the immediate release form. You do not take, repeat, you do not take the extended release if you happen to have restless leg syndrome. So if you're starting with restless leg syndrome about 1 to 3 hours before you go to bed, you take 0.25 milligrams on day 1, and for the rest of the first week, you take 0.5 milligrams. Then the second week, you take 1 milligrams once a day, not 3 times a day like you were taking with the Parkinson's disease, but you take 1 milligram for the second week, once a day, hour to 3 hours before you go to bed. Through the 3rd to the 7th week, you slowly increase the dose to a maximum of 4 milligrams once a day, 1 to 3 hours before you go to bed. Now, practically, that means that most people are controlled at around 2 milligrams a day. And to get all of these different doses, fortunately, the pill comes in a variety of sizes or strengths. So for the immediate release, it comes in the 0.25 to 0.5, and then 1, 2, 3, 4, and 5 milligrams. And the extended release, that comes in 2, 4, 6, 8, and 12 milligrams. And if you happen to be taking those 3 times a day of the immediate release and you say, I'm tired of this, I want to take just 1 pill a day, you can simplify your life and switch over to the extended release by just adding up all the total of the amount of your dose with the immediate release, and that's your dose of the extended release. But if you stop taking the pill for any reason, for more than a week or so, then probably you have to start right back at ground zero. You start and titrate from the low dose in order to minimize the likelihood of side effects. So if you have the Parkinson's disease, we use the United Parkinson's Disease Rating Scale to decide whether the medicine's working or not. And this looks at the mentation, it looks at your activities of daily living, it looks at the complications of therapy, and it looks at motor performance. It has a 14-item scale, and it looks at cardinal motor findings, so the tremor and the rigidity and the slowness of movement, the bradykinesia and the postural instability. And it looks at those areas in different parts of the body. And then we have a score, and the score could be a maximum of 108. If you're as bad as you possibly could be, your score is 108. So how does it work when we use it on patients? So in patients who have early Parkinson's disease, they did a study, 186 patients, fixed dose. They looked at the extended release versus the placebo, and they found that the greatest effect was at 12 milligrams a day, but interestingly, it wasn't statistically significantly different at any dose from taking a placebo. So on the motor score, it was reduced by about 4 points in people who were taking the placebo, and it was reduced by 4 points if you took the 2 milligrams, about 5 points if you took the 8 milligrams. If you took the 12 milligrams, reduced by about 6 points. If you took 24 milligrams, was reduced by even less than you got if you took the 12 milligrams. So it doesn't seem that the pill is a phenomenal success. But then they did another study. And these are in patients who were not adequately controlled with levodopa. And these individuals received the ropinirole at an average dose of about 19 milligrams. Now that's higher than is recommended on average. And they looked at the off time. And the off time was decreased by about 2 hours with ropinirole versus only being reduced by about half hour with the placebo. So it seems that ropinirole gave you an hour and a half more on time, and that's probably pretty good. And with the ropinirole, you were able to reduce the amount of levodopa you were taking by about a third versus in people taking the placebo could reduce the amount of levodopa by about 20%. So let's look at another study. They looked at the off time in advanced Parkinson's disease, and these individuals had an off time of somewhere between 5.5 and 6.5 hours, and they had a greatest improvement if they took 8 milligrams of the ropinirole a day. But it was much less dramatic. So now the placebo, instead of reducing the off time by only about half hour, it reduced the off time by about 2 hours with 4 milligrams of the ropinirole, also 2 points down. If you took the 8 milligram ropinirole, about 3 points down, 3 hours down. The 12 milligram, it's still only about 2.5 milligrams, and that's what it was at the 16 and 24 milligram. So it seems that we have even less dramatic improvement, and we also have some confusion between the ropinirole and the risperidone. That's because doctors write illegibly, and sometimes a pharmacist can make an honest mistake. There's overlapping dosage, and oftentimes in those computer menus for drugs that the doctor just telephonically sends over to the pharmacy, right next to the ropinirole is a risperidone, so easy to click the wrong button. And when they're called into the pharmacy, sometimes, depending on how harried the pharmacist is and how the accent of the individual calling it in, sometimes it's easy to make a mistake between those two drugs. Well, the story gets interesting because when it was approved for treatment of the Restless Leg Syndrome, RLS, it was thought to be a pretty slick medicine. Seemed not to have any kind of major side effects, but it was studied on a short-term study in only 300 patients. Well, in the years afterward, it was found that people who were taking ropinirole had an increased incidence of psychiatric illness. And it seems that it was probably related to the acting out due to the stimulation of the D3 receptors, the dopamine 3 receptors. And it led to pathologic gambling and hypersexuality, led to impulsive shopping, led to the mania of bipolar disorder. And then we had Public Citizen, that's a public interest lobbying group. They actually petitioned the FDA in 2016 to put a black box warning at a minimum, because about 1 in 6 people taking the ropinirole in a report that came out in 2010 showed that they had these kind of problems, these impulse control disorders. And it would appear that the psychiatric symptoms aren't dose-related because they occurred in people taking the Restless Leg Syndrome dose, which was much lower than the Parkinson's dose. Well, in 2019, the FDA said no. They issued actually a 39-page letter detailing their analysis of why there was a direct association that was lacking, but they did say that on the package insert they had to mention that there was possible manifestation of hallucination and psychotic-like behavior. Put that in the warning section. So what is in the warning section? The warning section on the package insert of the medicine says that sometimes people have impulse control disorder when they take the medicine. They have an intense urge to gamble or have sex or spend money or binge or act in other compulsive activities. They have an inability to control the activities, and they don't even typically recognize they have a problem. And additionally, some people have psychotic-like behavior. Psychotic-like behavior. They have behavioral change and abnormal thinking and paranoid ideations, and they have delusions and hallucinations and confusion and aggressive activities. They become agitated. Sometimes they become delirious. So that's all not very good. That's why it's fallen out of favor for the restless leg syndrome. Well, you could overdose on the medicine. And if you take more than 24 milligrams at a time, you might have some nausea or vomiting or cough or dizziness or sweating, claustrophobia, hallucinations, peculiar movements, we call it choreiform movements. You can have some palpitations or chest pain, some fatigue or some nightmares. So at least if a person already has a psychiatric abnormality, probably this wouldn't be one of the first choices. And as a matter of fact, sometimes when you use drugs to treat the psychoses, they actually can increase the symptoms of Parkinson's disease, and they can make the effects of ropinirole even less. So again, you wouldn't want to combine those atypical antipsychotics with the ropinirole. And sometimes the ropinirole might lead to the neuroleptic malignant syndrome, where the temperature, your body temperature goes up, muscles become more rigid, alters your consciousness, causes some autonomic instability with fluctuations of the blood pressure and the heart rate. And then it can lead to problems, especially when you change the dose or when you discontinue the dose. That's why you don't want to discontinue the dose suddenly. Now, there's another problem with ropinirole that's also very important. And this is a problem with the sudden onset of sleep or sleepiness. So you can fall asleep during your routine activities of daily living, like driving a car, operating heavy equipment, sometimes even without warning. And sometimes it doesn't even start till you've been on the medicine for a year or even longer. So again, caution is urged. And sometimes a person who takes the drug can faint, oftentimes associated with a very slow heart rate. So it's not for people who have some sort of impairment in the cardiac conduction system, and can lead to hypotension, especially when you stand up. We call it orthostatic hypotension, when your blood pressure falls by more than 20 millimeters on the systolic or more than 10 millimeters on the diastolic. Sometimes people develop symptoms of dizziness or feel like they're going to faint. Oftentimes happens with dose escalation. Well, contrary-wise, even though it can lead to a low blood pressure and make you faint, sometimes people taking the drug develop elevated blood pressure and even an increase in the heart rate. So you have to be careful if you're taking the drug. And if a person has Parkinson's disease, there's about a 2 to a 6-fold increase in the risk of malignant melanoma. Now, whether it's due to the disease or whether it's due to the treatment, we really don't know. But that means that if you're taking the drug periodically, you ought to have your skin checked. And it was found early in the studies that ropinirole might lead to some fibrotic complications. So it might lead to fibrosis or scar tissue forming in the lungs or in the pleural cavity or in the pericardial cavity or even in the cardiac valves. Well, you shouldn't take the medicine if you're hypersensitive to it. So in rare people, when they take the medicine, they get some hives or they get some swelling of the tongue or the throat. They can get a rash and some itch. You shouldn't take the medicine. What are the typical side effects? Typical side effects are nausea, about 20-30% of the people. Somnolence, that sleepiness, sudden onset of sleep, maybe about 10 to 15% of the people. Some dyskinesias and dizziness in 5 or 6%. Other common complications include the sudden fall of the blood pressure, especially when you stand up, or hallucinations or vertigo, dizziness, abdominal discomfort, 5 to 10% of the people. Sometimes people develop a dry mouth or headache, and it can suppress the prolactin. We'll get back to that in a minute. But it can suppress the production of a hormone known as prolactin. And with the restless leg syndrome, there's a problem with what we call augmentation. So even though you take the medicine for the restless leg syndrome, you might develop worse symptoms. So then you take a higher dose. And then the symptoms seem to get worse. And you keep taking more medicine and the symptoms seem to continue to get worse. That's what we call augmentation. And when you have the augmentation, really what you have to do is you have to get off of the medicine. Now, the withdrawal from the medicine is painful and it lasts a while, but eventually the symptoms seem to go away. Well, how does the dopamine, or how does the medicine work? It works on the dopamine. It increases the dopamine because it acts on the dopamine receptor. And the dopamine receptor, there are a bunch of them in the brain. And it seems that it works best on the dopamine 2 receptor, then the dopamine 3, then the dopamine 4 receptor. And it doesn't have any effect on the serotonin 1 receptor, but it's weakly active at the serotonin 2 receptor. It doesn't work on the acetylcholine receptor. It doesn't seem to have anything to do with GABA. So the medicine, fortunately, doesn't interfere with the major drug metabolizing enzymes, but some of the minor drug metabolizing enzymes it may interact with. So for instance, it interacts with 1A2. So the 1A2 is how it gets metabolized. So if you take a drug that's going to inhibit the 1A2 liver enzyme that metabolizes this particular drug, like if you take Cipro, typical example, it's going to increase the concentration of the ropinirole in your system by anywhere between 50 and 80%. On the other hand, if you do something to induce that enzyme is going to really degrade the ropinirole extra fast. So it's going to decrease the levels in the system by about 30 to 40% if you smoke a cigarette, if you take omeprazole. But fortunately, like I say, it doesn't seem to have any interaction with the 3A4, which is the major drug metabolizing enzyme. Well, if you happen to be taking hormone replacement therapy, if you're a woman over age 50 or so and you take the hormone replacement therapy, it might require alteration of the dose. And if you take a dopamine antagonist, like one of those neuroleptics, phenothiazine, atypical antipsychotic, Abilify, Seroquel, like Prexa, well, that's going to decrease the effectiveness of the ropinirole. Pregnancy, we don't really have any good evidence for or against it, but certainly in rat models, it causes problems, causes behavioral problems, causes some teratogenic problems at increased dose, it's lethal to the embryo. So definitely not a good drug to take if you happen to be pregnant. And for lactation, remember I said it decreases the prolactin. You need the prolactin to make the milk. So low prolactin, less breast milk. So again, not appropriate. It's not studied in the pediatric population. In the older population, it's possible to have a slightly increased amount floating around in the system because you can't degrade it relatively rapidly. If you have kidney disease, mild kidney disease, there's no problem. It's not been studied in severe kidney disease. And again, if you have liver disease, well, it's not specifically studied, but it's metabolized in the liver. So it's not really meant for people who have moderate to severe liver disease. Once you take the pill, about half of it's going to get into the system, about 40%, more if you take it with a high-fat meal versus you don't take it with any food. But if you take it with a high-fat meal, it's going to delay the time to the maximum concentration by about 3 hours. Metabolized very rapidly. The first pass as it gets through the intestine and goes to the liver, already half of it's going to be broken down. The mean time to the maximum blood concentration is going to be about 1 to 2 hours if you take the immediate release, but if you take the delayed release or the extended release, it's going to be about 6 to 10 hours. About 40% of it is going to be bound to the different plasma proteins. It's going to get to a steady state in about 2 days with the immediate release, 4 days with the extended release. You're not going to have as much if you take the extended release. The blood levels are going to be lower. Half-life of the drug is about 6 hours. It's metabolized in the liver, so that's why you have to be careful if you have moderate to advanced liver disease. About 90% is going to be excreted in the urine. Less than 10% goes out as an unchanged drug. Carcinogenicity, yeah, they're little problem. It's not thought to be relevant to humans, but in rats, they can get some testicular adenomas, any dose, and in mice, they can get some uterine fibromas, polyps. It's not mutagenic. Can cause a problem with fertility and implantation. That's possibly due to the decrease in the amount of the prolactin. And interestingly, it seems to bind to some of the pigment cells in the retina. We don't know what that really means as far as humans are concerned. Well, the question always comes down to how much does the drug cost? If you take the immediate release ropinirole, 1 milligram, 30 pills, going to cost you anywhere between $10 cash and $100 if you go to Walgreens. You could buy it with a coupon from GoodRx for as low as $9, but it's going to be $28 if you go to Walgreens with the coupon. The brand name Requip's no longer available because I said that they can't compete with some of these prices. Now, the extended release, 8 milligrams, 30 of them, so a month worth, would be about $211 cash. Unless you go to Walgreens, it's about $260. If you have a coupon from GoodRx, you can buy the same medicine for anywhere between $56 and $69. Now, here's where they get you. If you want the brand name, so 8 milligrams of Requip, the extended release, going to cost you with a coupon anywhere between $440 and $480 for a month. Something that you could buy for considerably less with a coupon from GoodRx at any drugstore. Works exactly the same. It is basically exactly the same. So that's ropinirole. It's probably a good medicine by itself for early Parkinson's disease, probably as an add-on to levodopa for more advanced disease. Originally, it was thought to be a pretty good drug for the restless leg syndrome, but it's fallen out of favor for two reasons. One, because of the impulse control disorder, and two, because of the recognition that it can lead to worsening of the symptoms. Initial improvement, but then ultimately worsening of the symptoms. So you want to be careful. And add to this, you have all of the other kind of manifestations associated with it, all the other psychiatric manifestations, and the tendency to fall asleep all of a sudden when you're driving a car. So if you're going to take the drug, just be aware of some of the downside. Anyway, thanks for watching. If you enjoyed the show, please tell a friend, consider subscribing so you'll be notified as we post new videos. I appreciate your interest. I'm Dr. Ken Landau.